Great. Well, I know it's 1 minute past the hour. I think we can get started. Again, welcome everyone. Good afternoon or good morning, depending on where you're calling in from today. My name is Samira Mackey. I'm the project manager on the Moving Forward Coalition. And my colleague and the director of the Moving Forward Coalition, Isaac Longobardi, is also on our call today. Thank you all for joining us in another one of our webinars, spotlighting each of the 9 action plans we launched in July. In today's webinar, we'll be learning more about the Enhancing Surveyor Training on Person-Centered Care Action Plan, about how to support state surveyors in assessing, reporting, and evaluating practices of resident-directed living and person-centered care. As I mentioned earlier, we would love to see who's joined us on our call today. Please introduce yourself in the chat so we can all see, and would encourage you to scroll down to see who else is on the chat. If you could share your name, your role, where you're calling in from today. And I know some folks have shared why this work matters to them. And before we get into it, we want to first thank the John A. Hartford Foundation for generously funding the Moving Forward Coalition. This work could not happen without them. So in our call together, at the beginning of this call, I'll be sharing a little bit more about the coalition and about our action plans before I pass it off to Joanne Rader and Doug Pace, who'll be sharing about their group's action plan to enhance surveyor training on person-centered care. And then we'll have some time for Q&A after their presentation. So please chat in your questions throughout the call. And we'll be wrapping it up with ways you can stay connected to the coalition and to engage with the action plans. And I know many coalition members have joined our call today as well, as I can see. So if at any point you have anything to add, please share that in the chat or speak up during the Q&A portion. So who is the Moving Forward Coalition? We are a diverse group of voices, individuals, and organizations who have come together to drive specific, actionable improvement in nursing home quality. And I think now there are about 1,300 individuals, including advocates, CNAs, nursing home providers, residents, direct care staff from all across the country who are in the coalition, making this a sustainable network to continue this vital work. And I know many of you, again, on this call today are part of the coalition. I think scrolling through the chat, we get to see a snapshot of how we brought different voices to the table. Our purpose is to develop, test, and promote action plans to improve nursing home resident quality of care and life. And we've just hit the end of our first year, and going into our second year, we're really going to focus on testing those action plans and implementing and piloting those action plans. And I'll be sharing a little bit more about what an action plan is and the process to how we got here. But just to give you an overview, each of the action plans describes a specific and particular challenge facing nursing homes, explains why it's important, and provides a step-by-step path to achieving them over the coming year. So we started this coalition without a vision or mission, and I know we've developed that with many of you on this call in the past year. And our vision is that every nursing home will be a community in which lives are nurtured, residents are empowered, and where people want to work. And we're going to get there by making vital changes in policy and practice through the power of bringing diverse voices together now. And how did we get to these action plans, you might be asking? Well, we started this coalition by looking at the recommendations in the NASEM report that was published in April 2022. I actually have it right next to me for those who might not be familiar with it. It's very lengthy, and it emphasizes the importance of a holistic approach to nursing home quality improvement. And we wanted to make sure that this report didn't just sit on a shelf and collect dust. We wanted to make sure that the recommendations in the report were actually put into action. And so we took this report and identified which of the recommendations we could prioritize as items that could be acted on and piloted on now. And in the end, the recommendations we prioritized captured all four of these elements in these four boxes. They incorporated equity, sustainability, feasibility, and collaboration. And you can see on our website that we ultimately prioritized 7 recommendations in the report that captured challenges across the nursing home as a system. So these are some screenshots of our lovely committee members. And I know we can see Doug Pace, who we'll be actually hearing from later today. And so across many calls, the action plans were developed where we looked at emerging research, new partnerships, committee collaboration to make sure that the folks who need to be at the table were at the table. And of course, central to this was what matters to residents. And by continuing to build on that work, we were able to publish the following 9 action plans. And in today's call, we'll be learning more about the Enhancing Surveyor Training on Person-Centered Care action plan. So with that, Doug, I will pass it over to you.
Great. Thank you so much, Samari. And thanks to all of you for being here today. And on behalf of myself and Joanne and members of the committee number 5, we're glad to have the opportunity to share with you information about the action plan focused on enhancing surveyor training on person-centered care. Now, committee number 5 is based off the NASEM Report goal number 5, which is focused on designing a more effective and responsive system of quality assurance. And this action plan was developed by a work group comprised of representatives of consumer advocates, representatives from the provider community, culture change pioneers, ombudsman, quality improvement experts, and we also had a CNA and a resident of the nursing home on our work group. So in order to improve the quality of care and the quality of life of residents in nursing homes, our committee believes that surveyors would benefit from additional training on how to assess, report, and evaluate the delivery of resident-directed living in nursing homes. And we all know that improving the quality of care and the quality of life in nursing homes has been at the forefront since the 1986 IOM report and the passage of OBRA 87, which mandated that nursing homes provide services and activities to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident in accordance with a written plan of care. But we're now 35 years past the passage of OBRA 87, and we know that nursing homes are still struggling with transitioning from a staff-directed system to one that's more resident-directed. And there's many complex reasons for that, as are outlined in both the IOM and the NASEM's reports. But look at a snapshot of today. Today, there's about 15,600 nursing homes in the US. And approximately 16%, or almost 2,500 of them, are one-star nursing homes. And approximately 20%, or 3,100 of them, are two-star nursing homes, where combined over 500,000 Americans live. And also almost half of them have Alzheimer's or other dementias. So we believe now is the time for bold action and swift change, not only for today's residents, but also to prepare for the future. Samari, can you show the next slide? So this slide is from the NASEM report, and it depicts the committee's vision of nursing home quality, which is that residents of nursing homes receive care in an environment that honors their values and preferences, addresses goals of care, promotes equity, and assesses benefits and risk of care around balancing safety and autonomy. However, as the committee's evaluation of the evidence they found in the report, this model of quality care is not the reality in many nursing homes today. So you can see that this model has 3 major components: inputs on the left, nursing home care in the middle, and outcomes. And as you can see on the left-hand side, oversight and regulation is one of the many important inputs into ensuring nursing home quality. But unfortunately, many times the survey process doesn't fully encompass the whole concept of resident-directed living and rarely focuses on resident, family, and organizational outcomes and the importance of evaluating quality improvement outcomes as a crucial part of the survey process. So this slide is on page 39 of the NASEM report that Samari mentioned, and I would encourage you to review this slide and the full report as well, and Samari can put a link in the chat where you can download that full report. So you can take that slide down, Samari. We also know that the CMS State Operations Manual, which provides guidance to the surveyors in nursing homes, states that person-centered care means to focus on the resident as the locus of control and to support residents in their own choices and having control over their own daily lives. So this defines more than just care. It defines how the resident in a nursing home wants to live. So this surveyor training focused on person-centered care, or more accurately, resident-directed living, is not meant to replace or alter the current training that the surveyors receive from CMS, but to build upon that training with an increased emphasis on ensuring that the voice of the resident is front and center during the survey process. Also, on May 18th of this year, the U.S. Senate Special Committee on Aging held a hearing titled Residents at Risk: The Strained Nursing Home Inspection System and the Need to Improve Oversight, Transparency, and Accountability. And this hearing highlighted many issues with the current survey system, including many states having high staffing survey shortages and high turnover rates. But in addition, as Samari mentioned, the Moving Forward Coalition is committed to the residents having a voice. So we asked them, and here's what we heard from some of the residents about the survey process. Residents are generally unsatisfied with their ability to meet or talk with surveyors. They told us that they experience surveyors sometimes as unwilling to listen what the resident thinks is important. This one really amazed me. None could recall being asked whether the care plan and the things that are most important to them have actually been implemented. They also said surveyors need to make it safe for people to talk to them, and the process of selecting residents needs to be more transparent. And finally, they said to us, surveyors need training in quality of life, resident well-being, person-centered care, and what is important to residents. So now I'm going to turn it over to Joanne, who's going to continue the discussion on why surveyor training related to culture change is so important. Joanne?
Okay, thanks, Doug. Yeah, people wonder, like, well, isn't this already being covered? But we actually looked and asked how resident-directed living, as we like to call it, is being taught to surveyors at the federal and at the state levels also. And basically it was very minimal in terms of just sort of looking at what FTAGs it might be related to. But you know what? Resident-directed living is a lot more complicated than a regulation. It involves something that we've called culture change, which is where there's a real dramatic shift in the way we look at how care is provided. And that goes all the way up and down the continuum of care, from the way CMS is viewing it, the way the owners and corporations are viewing it, and the way the direct care workers and the residents are viewing it. And so it's something that has to be taught, and it has to be taught by people who've had some experience in trying to implement this. Again, the word culture change is being used in the NASEM report to talk about the needed changes many, many times. I think there's like 90 times that it's mentioned in that report. And it's a confusing thing for people to understand. So let me bring up a slide or a PDF right now that sort of helps to illustrate what I'm talking about. So this is what we call, this is labeled now the continuum of person-directed care. And I've been in this business for 50 years as a nurse. And I did a lot of the last few years have been, many years have been spent as a clinical specialist in mental health nursing, really focusing on folks with dementia. So when I started, and what's really still out there, is the provider-directed approach, where management makes most of the decisions with little conscious consideration of the impact of the elders or the staff. And basically, I'm not blaming anybody here for this. It's just the old hospital model that we sort of incorporated as the way we should be providing long-term care. And that decision was made in a number of ways, maybe 40 years ago, and that still lingers on. Well, moving from a provider-directed model, or you could say also a medical directed model to one that really embraces person directed care and citizenship for residents is it's a step-to-step process. It doesn't happen overnight. So one of the ways you would move forward would be staff-centered, where the staff might consult with the elders and put themselves in the elders' place while making decisions, and yet still the regulations or the way they're being interpreted and the policies don't allow for personalization as we all want. So then we move to person-centered and person-directed. And in person-directed, elders make decisions every day about how their individual routines are to go. And when they're not capable of sort of articulating their needs, the staff honor their observed preferences and their lifelong habits. It's a very different model. And in the citizenship model, elders have influence on their community. They're problem solvers. And this includes people with dementia, which are very capable of having very brilliant ideas about how to solve problems. And they share responsibility for each other. So it's a very different model. And there are different practices that are in different places. So it's a different mindset. And for example, something as simple as if a person wants an Oreo cookie in a provider-directed model that doesn't have any flexibility or any snacks on the unit, which is what it was called, versus the household, if you're moving towards a more pod-type model. Getting an Oreo cookie can be a really hard thing to do. You have to go get permission from somebody. You have to go to the kitchen to see if they have it. Whereas if you're in the resident-directed living model, you're going to have those snacks because you know the person likes it and it's going to be on the unit and they have access to them. They can often just get them themselves, even if they're diabetic, if that's what they choose to do. So you can see that that's a big shift. And that shift can't occur unless everyone that's a part of the process has the similar, a common understanding of what this means in practice. And that's why, and you can take that slide down now. That's why in practice, it's so important that all stakeholders understand how this is going to look very different in practice. That residents have the rights to take risks just as you do, and that isn't taken away from people when they come into a setting. But that's a very important mind shift that has to occur. And providers, when they're trying to make the transition to give residents more power for decision making and take more risks, of course they have to be informed about what the risks are, and it's calculated, and it's often complex to try to figure out the solutions. But they need to know that the surveyors are understanding of what they're trying to do. They need to understand that protective services are understanding of what's trying to do, that the QIOs, that everybody is on board in understanding what this shift is all about. Now let me give you some examples of how this has been done in the past. This isn't necessarily a new concept that we train surveyors in person-directed care. Actually, back in around 2000 to 2008 to 2010, there was a lot of work that was being done at CMS to help people better understand this, to help providers, to help surveyors. I was a part of making some videos that helped explain some of those concepts to surveyors. It was part of the training that all surveyors receive. That's not currently in place right now, and that's why we feel the need so strongly to bring back trainings. And the training surveyors by themselves is helpful, but it's much more effective if it's collaborative, where all the stakeholders are hearing the information in an educational format at the same time and have the opportunity to ask questions from their various perspectives. One of the examples that I, long ago, this was like 30 years ago, 1990, in Oregon, about 50% of residents in nursing homes were restrained in their chairs and their beds and things like that for their own good. That was the accepted practice. That's what surveyors were looking for. And no one was really looking at the damage that was being done to them, damage including death from suffocation and strangulation from the restraints. So we learned more. We learned how to do it differently. And even pre-OBRA in Oregon, we got a grant to try to change that practice. And what we did was we got together with the surveyors and the protective service people and the ombudsman and the providers. And we had a steering committee that looked at how we wanted to move towards a more person-directed care model and get rid of physical restraints. And that's what we did. And we were very successful in doing that. But it was through the collaborative training and education of surveyors and also a group that could problem solve around things. We found that sometimes the way surveyors were writing regulations or writing citations led providers to believe that they needed to continue the practice of using physical restraints because it was written on their care plan. And there were a lot of misunderstandings because it was a dramatic change in practice, just as what we're asking to do now is. And again, all we're really asking is to implement the regulations as they exist. And as Doug mentioned, bring the meat of OBRA with the bringing people quality of life really into practice. So we were very successful with using that model. We went all around the state and provided trainings and opportunities for people to learn together, with the surveyors being a big part of that. There was another example that was done in 2006 to 2008 in 2008 in Rhode Island through a Commonwealth grant, where the Department of Health in Rhode Island and the state Surveyor organization, in collaboration with CMS, used the mandated regulatory process. And we already had the things in place to make this happen, but they worked together to motivate and enable Rhode Island to better implement and fully realize the potential of resident-centered care, resident-directed care, and what's inherent in OBRA 87. So again, this was a project that was done throughout Rhode Island. It was finished in 2008, and they had some key lessons that they learned. One was that organizational leadership and effective participatory teamwork is essential. So we took that information and we spoke to some folks from Rhode Island and said, this is something that we have to try to put into the surveyor training model that we're trying to do through the moving forward. The other thing was that multiple stakeholders must participate simultaneously: QIO, QAPI, ombudsman, surveyors, providers, protective services, that they must participate simultaneously in order for it to really work and go into practice. Well, what were the outcomes of the Rhode Island thing, the Rhode Island project? Well, they created supplementary survey tools. They completed 51 pilot surveys. Surveyors were trained in recognizing and assuring individualized care and compliance. There were educational partnerships between the survey agencies and the QIOs. The websites created resources for both surveyors and providers, and they created 5-module training manual toolbox for surveyors and providers. So a lot of work has been done in this in the past, and we can learn from that when we're finishing the last year of this project. But the outcomes have been that there's been a decreased misperceptions of the fact that people believe that there are regulatory obstacles preventing resident-directed living from occurring, and actually it's just a better implementation of the laws that already exist. And the other thing is that they found that when they were doing the surveys, that they had more citations related to individualized care, which is what we're looking for, and that there was a better opportunity for the providers to learn how they could be doing it differently. Now, the one in Oregon and the one in Rhode Island aren't the only examples of how this has been done in the past. Colorado had a lot of collaborative training with surveyors going on a number of years ago. Kansas, through their PEAK, P-E-A-K program, had similar things and have similar things ongoing right now. In Wyoming, a woman by the name of Carmen Bowman used some CMP monies to do some basic training on how to implement culture change and person-directed living to nursing homes. And this was done through a webinar over a series of months. And it was amazing what she was able to do with that format to try to help providers to make a change in, now she wasn't really involving surveyors in that process, but it showed that a ongoing educational process can be extremely helpful in helping all stakeholders to look at the situation in a way that is more embracing of resident-directed living. So I think there's an underlying fear that if there's more collaboration, there can be less compliance. And I think that needs to be challenged, because I think in the models that I've participated in and the ones that I've explored, we found that more education and collaborative education can only be helpful. And so I think I'll just end right there. And because right now I don't believe that we're currently in some states, there's a lot of variation from in state to state, but I believe there's a lot of places where that's not happening, and we'd like to, through this project, help bring that knowledge to surveyors and others who need it to make that change. Okay.
Thank you so much, Joanne and Doug. A really wonderful overview of the history, issues, and work. Doug, I see a finger. And I notice we have one question in the chat, and I'm also wondering if you could share with the group a little more about your work for the coming year and how you're pushing this forward and helping generate momentum around this critical work of surveyor training and bringing surveyors into culture change more broadly.
Sure, Isaac, and thanks. That's what I was going to do with this next part, so you're right on target. So what are we proposing? We're proposing a 2-day surveyor training to a select group of surveyors in one or more states that will include training on how to assess, report, and evaluate nursing homes on the delivery of resident-directed care, including person-centered care goals, care plan documentation of resident goals, preferences and priorities on whether or not those goals are being integrated into the care delivery of the residents. This training will also include participation of the long-term care ombudsman, quality improvement organizations like the QIOs, and staff and residents of nursing homes. So our timeline to complete at least one of these trainings is by June 2024, which is the end of year 2 of the coalition. So where are we? We are currently in discussions with a few state survey agencies about partnering with them on this training. It includes active discussions with one state where we might build upon our original proposal, which is to expand the audience to not only surveyors, but as they did in Rhode Island, also expanding that to include providers, long-term care ombudsman, and the QIOs on day 1, and then possibly the surveyors only on day 2 for some more targeted training. We've also discussed developing a monthly webinar series with a select group of surveyors to solicit their feedback on what is most important for them to be effective in evaluating resident-directed living. So, while the core of our action plan is set, we think it's important to have flexibility to meet any state's needs. Also, with this training, we will conduct a pre and post evaluation survey, and with that, produce a final report on the findings of the outcomes of the training. And we're also recommending that a longer-term research project could focus on involving a comparison group of surveyors receiving training on person-centered care versus usual training over time, and the findings could then be presented to CMS, HHS, and policymakers. And we believe that this action plan could lead to some longer-term goals, such as expanding the training to all surveyors, or requiring all newly hired surveyors complete the training before going into the field. Now, it's important for all of us to remember that during the State of the Union address on March 1st of 2022, President Biden announced that reforming nursing homes is a national priority. And you may or may not know, but that was the first time in history that a U.S. president has explicitly stated during a State of the Union address a desire to set higher standards for nursing homes to make sure that the loved ones get the care and support they deserve and respect. So we believe now is the time for action, and investing in this type of resident-directed surveyor training will not only improve the quality of care and the quality of life for nursing home residents, but it'll also help prepare the surveyors with better tools and resources when they're conducting their survey activities. And also, this action plan is a great example of how a public-private partnership can be utilized to prepare the surveyors with better tools and resources in conducting their activities, along with some short-term and long-term metrics for success. So we would encourage any of you that are here on this webinar today to reach out to us if you can help connect us with state survey agencies in your state. So I think Isaac and Samari, I'll turn it back over to you, and we look forward to hearing from the group. And also I see Kathy Bradley, who is also a member of this work group on the call as well. And Kathy, you may have some comments to add as well.
Terrific, Doug. Thank you. And sorry for jumping the gun earlier. I have a few questions in the chat, and I'm just going to go in order. The first reads, what about the issue of surveyors or survey agencies working more on the side of the provider facility, listening to CNAs or administration rather than residents or family? Has this been documented, and is this perhaps one reason why complaints may come back unsubstantiated? And I think more broadly, I guess, can you speak more to perceptions and issues of imbalance in the survey process, and perhaps bias?
Well, I think I'll start, and then Joanne and Kathy, feel free to weigh in, or anyone else as well. It's important that all voices be heard during the survey process, and certainly hearing from those frontline staff, hearing from the CNAs. And again, we had a CNA as part of our work group, and I believe all of the work groups really have worked hard to have that voice of the CNAs through this process of the Moving Forward Coalition. So, everything we talk about is a team-based approach to care. And if you're really going to improve quality in a nursing home, then it is a whole team-based approach. But we also must remember, just as it's important to hear the voice of the CNA, it's also important to have that voice of the resident as well. And as you can hear, a lot of times that's not currently happening. Joanne referenced the project that the Commonwealth Fund had in Rhode Island several years ago. And we looked closely, and I would encourage all of you, there's a couple of really great overviews of that project, and they really had some tremendous success. And again, taking this sort of a whole approach to care and making sure that everyone has a voice in that. But Joanne and Kathy, anything you would add?
Yeah, I would just say that, one of the things that we're also working on through the, is accountability and transparency, which is important, in terms of how decisions are made in care settings. As Doug said, in Colorado, there was satisfaction on both parts for the process of the collaborative education and working together, in where that everybody felt that they benefited. I can't argue that, with the piece. I'm sorry, I'm not more articulate on this, but it's like I have not personally seen, and now I worked in a nonprofit care setting that was very much dedicated to person-directed care before we even had that title. But I'm sure that might occur, but I'm not sure that's. I think that fear can. I think we deserve a chance to show that collaboration is a helpful process where everybody can learn and everybody can win. Here, let me read you something that comes from a friend of mine, Barry Barkin. He's working on the Moving Forward committee also. He said, our first prime directive, these are culture change prime directives, is all that we do is directed towards supporting the human spirit to thrive. And this is primary directives for everybody. And the second prime directive is we continuously strive to eliminate policies and practice that diminish the human spirit. And that's the policies and practices on all levels. If you have a policy and practice that says that people can only be bathed at certain times of the day or by certain ways, that needs to be looked at if that is not allowing people to thrive. So again, it's a very different mindset. It's not a we-they mindset. It's a how are we going to come and accomplish these goals together. I saw another question about the Rhode Island project. Can I address that, or should I just wait, Isaac?
I was just gonna raise that.
Okay, the Rhode Island project was back in from 2006 to 2008, and it was not continued. So I'm not surprised that, you know, the question, I can't see it right now, but it was that's not what people are experiencing. And I would say that unless you're in care settings that are consciously working on creating culture change, that it's not going to be what people's experience is. And that's exactly the very thing we're trying to get at. I would encourage you, if you want to see how change is possible, and this was even took place during COVID, is you Google Wyoming nursing homes culture change. And you'll see a series of videos that was done and describes what did change. And this is in provider voices, when someone was giving them some information about how to look at things differently. They were looking at sleep. They were looking at eating, you know, meals and things like that. And it's a really good example of how a little bit of information can be taken by providers, and they can run with it, and they can start finding the joy back in caring that they had before. If they were working towards culture change, it kind of got dissipated during the whole COVID process, as we all know. So I mean, again, I have 50 years experience as a nurse, and the only thing that I have seen that really works to make a real difference at the level of the resident, where the resident experiences something day to day differently, is through the process of collaboration and culture change.
Thank you, Joanne. So I have I'm surveying our audience here, and I see a number of folks who are care partners or family members, and I'm wondering if you can speak to the role of care partners and family members in the culture change movement, and then also in what you all envision for the future of survey. Is there a place for those folks in survey going forward? And if so, what does that look like, and how do we get there?
Well, you know, I could certainly start, but if you look at the background of Kathy Bradley's screen, I think it's much more important for Kathy, you to weigh in on that, and then I'll add some comments.
Thank you, Doug. I'm glad to, always glad to be an advocate. Yes, I was a provider of long-term care services who was also an advocate for the consumers of those services. And then I became a family member of folks receiving long-term care services throughout. And I've been in this business since 1975, so not quite as long as Joanne, but I'm getting there. And it's been my observation, my experience, that without a voice of the consumer, systems tend toward staff convenience. And that's what the folks are talking about when they refer to the staff not knowing about person-centered care, and the providers and the surveyors kind of working together without the voice of the consumer being considered. And I had to become my mother's voice. She was a lifelong activist for social justice for groups without a voice in our society. And the first thing dementia took from her was her ability to speak. So she became a member of a group without a voice. I became her voice, and my family was instrumental in insisting on culture change in Mama's facility. She lived to benefit from that, and everybody in her facility benefited from that culture change. It is something that would not have happened if it had been left to staff to initiate the culture change. They had to be incentivized into accepting the concept of culture change. But to Joanne's point, once that culture change began to happen, staff became empowered just as residents became empowered. And when that happened, they saw their voice made a difference, just as the residents' voice made a difference. And they began to share ideas. And before it was over, and I give this example, it may not be the most important example, it is important, but it's also one a lot of people can relate to. The first 2.5 years Mama was in long-term care, every 6 weeks, she had dehydration and urinary tract infections that resulted in her being hospitalized with IV fluids and IV antibiotics every 6 weeks. I, who lived 86 miles away, had to be the one to say, you have got to test her. And then she would end up, sure enough, in the hospital with these illnesses. When we were able to begin to get culture change to happen in her facility, they implemented an actual hydration program, not just sitting a cup of water with a straw in it down next to the bed, right? And saying, oh, they've got fluid, but helping them drink, making sure they swallow it frequently throughout the day. Everybody in that facility, including my mother, Mama went for the last 2 years of her life with no dehydration, no urinary tract infections, no hospitalization. Everybody else in her facility had the same outcome because the staff were empowered. They
Absolutely.
knew the residents. They could make decisions about the care of the residents. They bought into it. Now, it usually takes a push from, the outside, that'd be me, to start to make that happen, because staff get complacent with a staff-centered approach, even though it's really, truthfully, more work for them. There's something they're used to. But once that change starts to happen, they begin to see the value of it. They begin to buy into it, and it snowballs, and good things can happen. Now, it has to come from the leadership. The leadership have to be committed. The staff have to receive competent supervision. They have to receive competent training. They have to have ongoing supervision, ongoing competent supervision, ongoing training to keep them competent. But it works. And I know as a provider as well as an advocate for a recipient. And that's why I'm involved with Moving Forward Coalition.
And thank you, Kathy. And again, you said it so well. And Isaac, I think it is important and to make sure we know that almost half of all residents in nursing homes have Alzheimer's or some form of dementia. And so certainly it's important to not only know who that person is from their voice, but also from the family and the care partner's voice when that person is not able to speak for them as well. And I will put my Alzheimer's Association hat on for a moment and just say there's a great resource if you go to alz.org/quality care. In 2018, we developed dementia care practice recommendations that are for all professionals working in long-term and home and community-based services. And we worked with 27 researchers looking at the latest evidence around what good quality dementia care looks like. Not surprisingly, it's with a person-centered care focus. And recommendation number one is to know the person. And so, and as Kathy said, and as Joanne said, culture change isn't just about the administrator saying, hey, we're gonna change today and that's automatically gonna happen. It's got to infiltrate through the whole building. And really it's the top really setting the stage, but really building it from the bottom up. Because if you don't have the CNAs, the people working in dietary, the housekeeping people, all of them having the knowledge and skills that it takes, then you're not going to succeed. We also know that, we're approaching a different time right now. We've been through a pandemic. We were making a lot of success in the person-centered resident-directed living movement. And then we had a pandemic, and naturally infection control had to be the most important thing during that time. But now we're hopefully on the other side of that. And now is the time to go back and learn from things that we've learned from Rhode Island, from Colorado, from all these other states, and to learn from Joanne. As Joanne said, those of us that have been in this working in long-term care for a long time, we remember the days where people, if you were in a nursing home, you were tying down residents. And we thought that was the right thing to do. But we now know that's not the right thing to do, thanks to Joanne and her work and the work of many others. So we have to continue to be innovative, to think differently, and to always put the resident and their wants and needs at the center of everything.
Oh, go ahead, John. Sorry.
I was just going to say, I'm reading some of the comments at the side. I'm not really good at listening and reading at the same time, so I'm trying, but you know, I hear people's frustration. Things out there now are not good, They're in some ways, they're the worst I've ever seen. And that's saying something, because I go back, like I said, 50 years. And COVID, of course, is a big factor in that. And the lack of staffing that we have, and trying to attract people to the staffing. And as people described, if you're being told by the DON or somebody what to say or not to say to surveyors and you have to be there, that's not empowering CNAs. If you've got culture change going on deeply in your care setting, that's not necessary, because as Kathy described, that direct caregiver, if she is consistently assigned to the same group of people so she knows them, now you got to have enough staff to do that. And you have to be able to track the staff to do that. And that's one of the benefits of culture changes, is if you look at the data that's out there, the one group that really got a lot of research done on this was the greenhouse projects, which is done in a pod household model. And their staff turnover rate is much lower than other places. Their COVID rate was much lower. Now, they had a lot of environmental things going in their favor also for that during COVID. But when people start embracing this, and I agree, it's okay for some of the pressure from that to come from the surveyors. That's kind of why we want to train them, in how to do that. That's why we want to link them with QIO, so that if they see that, then the QIO can come in and say, I'm thinking of your mom, Kathy. It's like, so yeah, so a lot of places have set up, I don't want to call them hydration stations, because that's not what you have in your home, but just, those, what do you call it, urns that you put out where everybody can go and get water that has lemon in it, a lemon ice water or something. And there are very simple ways that, just as you would do at home, that things can be done to turn around dramatically, like what you said. Look at the impact that had on your mother's life. And it was a simple solution. And there are a lot of those out there. But so I'm okay for the pressure to come from the surveyors, to make this change. And that's what this is about. But it can't be done without bringing in the voices of the residents and the families and the providers. I have to stick up for the people that are actually doing the work in nursing homes now. It is not a high-paying glamour position. The people that stay there, by and large, by my experience, are doing it because they have a love for the people that they're caring for. And sometimes they have to provide that love in an environment that is not supportive of them in any way. And that's what we're trying to do, because as part of culture changes, you move the decision-making to the bedside, and the person that knows the most is either the family member, the resident, the family member, or the staff member. And that's part of what we're trying to teach, that's how it should occur. But it can't occur like a rogue person doing that. It has to occur in a systematic way that a facility is embracing things. And I'll tell you, when I was doing this stuff on restraint-free care, at first there were people that, there always are, I guess, we call them the early adopters. People go, okay, I hear this, I see this, I see how this was wrong, and I'm going to change. Those are the early adopters, and they lead the way. And then they're not the early adopters, excuse me, they're the innovators. And then you have early adopters, and people go, yeah, okay, all right, they've tried it, it kind of works, so I'm going to try to give it a try too. And then you have people who go, I don't see it. This is the way we've always done it. We're not going to change. And they need a bit of a push. And that's how that's what the regulations are supposed to do.
Mhm.
But let's make it balanced. Let's make sure that we're looking at the things that really matter to the residents and not some superficial things that is not really important to them, and like whether or not their bed is made in the morning. It might be important to some person, but to another person, they would rather have somebody sitting on their bed and helping them with a game or something.
So
And I want to
go ahead, Kathy. Go ahead.
I'm looking at the chat as well, and people are asking really legitimate, really good questions and making good points. And I just want to say, don't anybody think that this is all there is to this, okay? There are 9 action plans that address 9 different aspects of the needed changes to improve nursing home care in this country. This is one part of one, okay? And it is not the end. It is not where, we're going to do this and everything is going to be fine. This is the beginning. And we're not stopping. We're not giving up. We intend for this to be the first step forward in this specific subject area. And so if you want to get a more comprehensive view, then, attend some of these other meetings, look at the report, look at the action plans that the Moving Forward Coalition has developed out of the report and recommendations in that report. And if you're only going to read one thing, read the recommendations, because it's a 570-page report. Yeah. It takes more than one bedtime reading to get through it. But the point is that we are all aware that this is not a one-step solve everything kind of situation. And so we're working on a lot of different fronts right now. And all of the work that's being presented is work that can be accomplished step 1 in maybe a year's time. Beyond that, it will keep growing. At this point, I have faith. I'm stepping out on faith that it's going to keep growing, and we're going to continue to move forward and gain momentum and gain a breadth and depth of influence and impact. Mama passed away in 2015. It's 2023, and here I am sitting here. So it's not just about Mama, although it is about everybody who's alive today, and we want to have impact immediately. But we recognize that there are going to be people to come and go before we get this all fixed. Sadly, it's not going to happen tomorrow.
And
go ahead, Dave. Doug.
Yeah, I was just going to say too, I'm sort of scanning the chat as well, and as someone put in, I just want to make sure that I made myself clear around the issue of COVID. Certainly, COVID is not gone, but we are in a very different place today than we were at the beginning of the pandemic. And we're now moving to where we have the ability to look at COVID like we look at the flu and other issues. And so certainly don't want to imply that that's not an issue anymore, but we are back to a place where we can better really implement person-directed or resident-directed issues. Someone else mentioned something about behaviors. And I also think, and again, I encourage you to look at our dementia care practice recommendations. We looked at the research, and a lot of times I think we don't use the best term when we talk about behaviors, dementia-related behaviors, because it's a form of communication for someone with dementia. That many times is the only ability that they have to communicate with you. And again, if you know that person, then you know what they're trying to say. And sometimes it might be their favorite music. Or as Kathy said and Joanne said, it might be just sitting down on the edge of the bed and holding their hand and talking to them. Or aromatherapy. There's many different things that we have in our toolbox now that can really help, and we have evidence behind those. And then the last point I want to make is we can't forget how important it is to train the staff and to give them the tools and the resources that they need. And we know we have a big issue with not only recruitment, but also with retention. So it's important to empower the staff with the training and the tools that they need to be able to know how to best care for the people in their care.
I just want to say, I hear everybody's frustration and I absolutely share it. We need a revolution, folks. And it needs to be led by consumers, families. Those are the people that the legislators are going to listen to. We need to be very vocal about that. This is our opportunity post-COVID to make major changes in how we deliver care. And major changes means we can't look to just putting in more regulations in place to make it happen, because that hasn't worked. We have the regulations in place. It's not working. And so we have to look broader for how we need to look at the whole system. And that, like we're saying, this is one piece. The accountability, transparency, all those things are really critical. So I applaud you for your passion for this. Talk to your legislators. You know, I'm talking to the head with somebody that's on the Senate Finance Committee or Budget Committee, trying to get a demonstration, a national demonstration project to implement culture change and a whole bunch of other changes to put this into practice on a much larger scale. But you know, people it's not high priority for them. So speak up, speak out, contact your legislators, but look broadly at it and not narrowly, and don't just blame the providers, the people that are actually doing the work, and see regulations as the solution as they currently exist, as they're currently interpreted. It's bigger than that.
And I just would add, Joanne, get involved with the coalition. To your point,
yes.
We're frustrated. I mean, we hear and that's the reason we all decided to join this coalition. And that's why, if you look at the NASEM report, it's an excellent report. And so the whole purpose, and grateful to the John A. Hartford Foundation for seeing the value in funding this coalition. You know, so get involved, work with us. You know, get involved in a committee. It's going to take all of us. But we all agree with you, you know, and if you look at the final recommendation from the NASEM report, they said the time is now, and it is. So join us in this work.
Thank you, Doug, Kathy, and Joanne. That was beautifully said. And I think it's a great segue into how you can all stay engaged with the action plans and to continue this discussion. And just, again, a big thank you to Doug, Joanne, and Kathy for sharing about the action plan today and for grounding us in why enhancing surveyor training, in-person centered care, and resident-directed living is part of ensuring resident-directed care and culture change. So how can you stay engaged in the coalition and the action plans? As Kathy mentioned, there are 8 other action plans. If you haven't had the chance yet, please do read the action plans. Consider how your organization can get involved in each of the action plans. We outline needed partners and opportunities for collaboration. If you're interested at all, please reach us at the email that I will chat in. And to stay connected and to be in the know of our coalition's latest progress and our upcoming events just like this, please sign up for our newsletter and follow us on LinkedIn, which I will also chat in. But with that, thank you all for joining today. Another big thank you to Doug and Joanne, and of course the committee, for continuing to work on the action plan, and we hope to see you in our future calls.
Thanks, everybody.
Okay, everybody.